protecting the well-being of children in the family courts, essentially assessing, diagnosing, and treating child abuse in the family courts. So in my previous half of this seminar, I discussed problematic situations in the current professional practices within the family courts. We need to substantially improve the quality of professional services being received by the children and families and by the courts. I recommend the discontinuation of the practices of forensic custody evaluations, that they are failed experiment service delivery to a vulnerable population, and we need to return to the established practices of healthcare and clinical psychology, diagnosis and treatment. Doctors diagnose and treat pathology. We do not make custody decisions. That's the court's domain. And the consideration for clinical psychologists is child abuse. The only cause of severe attachment pathology, a directional change in the child's attachment bonding motivations, is child abuse range parenting by one parent or the other. So we need to get a proper clinical diagnostic risk assessment for which parent is abusing the child so that we can take the proper treatment-related steps to resolve the situation. And so in this second part of the seminar presentation, I will be discussing the assessment, diagnosis, and treatment of the pathology in the family courts, beginning with developing an assessment protocol, or what is the assessment protocol for the family courts. Now, I recommend that all mental health professionals in the family courts document the child's symptoms and the family features using two symptom documentation instruments: the diagnostic checklist for pathogenic parenting and the parenting practices rating scale. And both of these are available on my website. You can go get them. And what these instruments are is symptom documentation instruments. They will identify the symptoms of concern in a very clear and way. And I have other presentations, other talks and writings about these two instruments. So the child symptoms are documented on the diagnostic checklist. That's attachment suppression towards a normal range parent, 5 narcissistic traits or a phobic anxiety displayed by the child, and a persecutory delusion displayed by the child. The parenting practices rating scale categorizes the targeted parents' parenting practices in one of 4 categories based on your clinical judgment of either abusive range, severely problematic, normal range problematic, or normal range healthy. So all diagnosis in healthcare, and I shouldn't have to explain this to doctors, but all diagnosis in healthcare is a pattern match of the diagnostic criteria to the symptoms. And so if the diagnostic criteria match up to the symptoms, that's your diagnosis. So if you pattern match to schizophrenia, you have the diagnosis of schizophrenia because your symptoms match the diagnostic criteria of schizophrenia. So the first step in diagnosis is to identify the symptoms. Then we will identify the relevant possible diagnoses that could produce a set of symptoms, and we'll apply the diagnostic criteria in turn to get a pattern match of which causal explanation is responsible for producing the child's symptoms. That's diagnosis. So start by documenting the symptoms. So the diagnostic checklist for pathogenic parenting identifies 3 diagnostic indicators. Attachment suppression towards a normal range parent, and that's your factitious disorder imposed on another, factitious attachment pathology. A child does not reject a normal range parent. 5 narcissistic traits or phobic fear displayed by the child, and all of these are false symptoms. And children don't have a narcissistic personality disorder. I refer to this number 2 as the psychological fingerprint evidence of psychological control of the child by the allied parent. So you can't control a child psychologically without leaving fingerprints of that control on their symptoms. So that's diagnostic indicator 2. And then a persecutory delusion displayed by the child. There's your shared persecutory delusion. And then I offer 12 associated clinical signs that are often present. And sure enough, the research indicates on 46 families, 45 of them had at least 5, and 45 of them had 8 or more. All of them had at least 5. So all 3 of those diagnostic indicators are impossible symptoms. Attachment suppression towards a normal range parent is an impossible symptom. Children don't reject normal range parents. It's a factitious attachment pathology. So that one identifies a FDIA. Diagnostic 2. 5 narcissistic traits displayed by the child is an impossible symptom. Children don't have personality disorders. Though that's the influence of the narcissistic parent on the child. And the child is being psychologically controlled by the narcissistic parent. Diagnostic 3 is the persecutory delusion displayed by a child is an impossible symptom. The child is actually has a shared persecutory delusion with the allied parent as the primary case. So these are all 3 impossible symptoms. But if they show up, it is because it's a factitious disorder. And you got the shared delusion as diagnostic indicator 3. Now, speaking of the 12 associated clinical signs, because I like these 12 associated, they're not diagnostic, but they help support the overall diagnosis, because here are 12 symptom features that I predicted will be present based on what the pathology is. I applied my knowledge, my expertise, and I said, these 12 symptoms will often be present. And sure enough, research on the families in the family courts, they are present. So this is up on ResearchGate. It's Greenham, Childers, and Pruder. You can go to ResearchGate and read it. So, and it was a poster presentation at the 2024 APA Psychological Convention regarding dark personalities and identifying the pathology in the family courts. So what the research did, this is out of Melanie Greenham. She's a graduate student in public policy now at University of New Mexico. So she got together with a data set that Dorsey Pruder has relative to her business called the custody resolution method, where she does content analysis on and tagging, data coding on all the data surrounding families. And so Melanie Greenham got a memorandum of understanding and an IRB through her university to conduct research, some research on Ms. Pruder's data set. And she got access to 46, the data compilation, data coding, tagging from 46 families involved in family court regarding the 12 associated clinical signs. That's one of the things Ms. Pruder tags for. She tags or codes for the 3 diagnostic indicators and 12 associated clinical signs. So we got a frequency count of the 12 associated clinical signs in the family. Now, first off, all 46 families had the 3 diagnostic indicators. So we have a clear definition of who these families are. We have the factitious disorder, shared persecutory delusion in the family, because all 46 had 3 diagnostic indicators of 3 impossible symptoms. So we're clear on what the pathology is that we're talking about here. Now, but the research was looking at the associated clinical signs. Are those present and how often? And interestingly, all 46 families evidenced 5 or more of the associated clinical signs, and 45 of the 46 families had 8 or more of the associated clinical signs. So they're not always present, but they're present a lot. And so here's a list of them. And you can go look on ResearchGate for this. So use of the word force was in 85% of the families, empowering the child to reject a parent, 100%. The exclusion demand, that child doesn't want them to at their soccer games or high school graduation, that's 63% of the family time. Parental replacement, calling the parent by their first name or things, is 54%. The unforgivable events, some past grudge that they can, is used to account for all future, rejection is 96% of the families showed that symptom. The use of the word liar or fake by the child. The child says, "Oh, my dad is fake. He's one way with everybody else, but he's different with me." That's 80%. 7% of the families showed that symptom. There's a set of themes for rejection. 100% of the families showed those sets of themes. Or unwarranted use of the word abuse. And so they're using abuse when there's actually no abuse there. That's 89% of the families. Excessive texting, phone calling, emails. This surprised me. This is one of the lower ones, 30%. I expected this to be higher. And role reversal use of the child. 96% of the child had, it's not me, it's the child who wants to go to this school, or the child who wants to do this thing. It's not me who's deciding. And then number 11, deserves to be rejected. That's the spousal abuse theme. Yeah, the other person deserves to be rejected because of some failure or inadequacy they have. And then disregard for court orders is 93%. So that's the frequency in the data for the 12 associated clinical signs. So they're often present. So what those are helpful with is you have the 3 diagnostic indicators. You have the parenting practices of the targeted parent are normal range. And so you've identified the pathology. And now if you have all that additional symptom set, of these associated clinical signs, you can be extremely comfortable in your diagnosis of a factitious disorder imposed on another, shared persecutory delusion, child psychological abuse, and then we can take appropriate treatment steps based on a secure diagnosis. And the other thing that these 2 instruments provide is a commonality of symptom identification among professionals. So the individual therapist should complete this. The family therapist should complete these symptoms ratings. Any assessing psychologist should complete these. And so everybody gets a clear understanding of what each other is seeing or not seeing in the symptom display. And so this facilitates clarity of communication among the professionals as well. So the second symptom identification instrument is the parenting practices rating scale. And that's to document either the abusive range parenting of the targeted parent or the normal range parenting of the targeted parent. This is either a true attachment pathology being caused by abusive parenting by the targeted parent, or is a false, factitious attachment pathology being caused by the allied parent. So this parenting practices rating scale is focused on the first aspect of that. Is the targeted parent abusing the child, or are they normal range? And so it breaks down the category of the parenting into level 1 abusive range parenting, and there's a bunch of anchoring points under those. So level 2 is severely problematic, not quite a diagnosable child abuse, but it's pretty bad, pretty severe. And then level 3 is normal range problematic. No one's perfect. Parents are could improve their parenting, but it's broadly normal range. It's not abusive range parenting. That would be level 3. And level 4 is healthy normal range parenting that there's really no concerns about. So that's just documenting their parenting for clarity in our diagnoses and then our interprofessional discussions. The outcome measure, I recommend we should always have an outcome measure in treatment, and that I will want to emphasize that again. We should always have an outcome measure in our treatment, and the child's symptoms should be guiding our treatment-related decision-making about what to do. Are the symptoms going up or going down, steady? What's going on? And so we should always have an outcome measure. Now, the outcome measure I recommend is a 7-point Likert scale on 3 items. And the targeted parent rates the child on these 3 items, 7-point Likert scale, every day, and emails those 3 numbers, just 3 numbers, to the family therapist every day, who puts them in an Excel file and then tracks the daily ratings of the child on three features. Affection, those are your attachment networks. We're monitoring those and how the attachment's going. Cooperation, that's monitoring emotional regulation networks. Are they locking up or are they flexible and cooperative? And social involvement, which is mood and arousal. Are they depressed and isolating, or are they socially engaged and available? So those are the three symptoms. Those are also the three symptoms that will be impacted by child psychological abuse. So if there's child psychological abuse by the allied parent, you're going to see damaged affection, damaged cooperation, and damaged social involvement with the targeted parent. So those are the symptoms we want to monitor, and those are the symptoms we want to get improved into normal range. We want normal range affection, normal range cooperation, normal range social involvement. So that's our outcome measure for this. Now, staff splitting. Okay. This pathology is narcissistic borderline dark and will engage staff splitting because of our own countertransference issues and ignorance about the pathology we're engaged with. Staff splitting is defined by Marsha Linehan, as mentioned earlier, is a much discussed phenomenon in which professionals treating, okay, let me pull that up for a second. Marsha Linehan indicates that this is a much discussed phenomenon of staff splitting. I haven't, in 10 years in the family courts, I have not heard this issue discussed at all within forensic psychology. So for the AFCC, we need to address the issue of staff splitting, and that needs to be addressed broader within the family courts. The professionals need to stop fighting around these children. All the fighting around these children needs to be brought down. We need to stop fighting around these children, and that includes the professionals. That's staff splitting. We become part of the pathology. It's associated with borderline personality pathology. So know what you're doing. Be competent. That's why it's important to know personality disorder pathology when you're working with personality disorder pathology. So staff splitting, as mentioned earlier, is a much discussed phenomenon in which professionals treating borderline patients begin arguing and fighting about a patient, the treatment plan, or the behavior of the other professionals with the patient. So we need to return to established knowledge and stop fighting. We need to apply established knowledge and reach a diagnosis so that we can effectively treat this. And if we have professional level disagreements, it will be around the diagnosis and whether that criteria for a specific diagnosis was or was not met. So courts decide on custody. Doctors treat pathology. And doctors need to return to their role as doctors. The professional fighting surrounding these children must end, and the professional psychology must speak with a clear, consistent, and accurate voice to the court. It is the obligation of professional psychology to properly assess, accurately diagnose, and effectively treat and resolve the pathology in the family courts. We're doctors, that's our job. We need to start doing our job. Doctors should remain doctors. The legal system is an adversarial system. Professional psychology cannot participate in the adversarial nature of the legal system. That is staff splitting. That is a symptom of the pathology. The obligation of professional psychology is to return an accurate diagnosis 100% of the time that the court can rely on for its decision-making surrounding the child. And we can do that when there's a motivation to do that. So earlier in the first part, I quoted duty of care obligations from Davies and Shaw. And I will return to the final point on that, which is specialists, such as psychologists working in the family courts. I would consider that domain a specialist domain. So specialists would need to exercise a higher degree of skill in their expertise on trauma, child abuse, delusional thought disorders, factitious disorders than would be found in the general public, and so are in the general population of psychologists. So doctors have obligations to be doctors, and we need to fulfill those obligations. diagnosis and treatment. Right now, professional psychology is failing in their obligations. We are failing the children, we are failing their parents, and we are failing the court. We are failing to protect the children. We are failing to return an accurate diagnosis to the court that the court can rely on for its decision making. Now, an additional area of concern regarding duty to protect and the differential diagnoses involved is spousal psychological abuse, a DSM-5 diagnosis of V995.82, another dangerous pathology that would activate duty to protect obligations and require either that the mental health professional conducts a proper assessment or they ensure that a proper risk assessment for possible spousal abuse gets conducted. So the spousal abuse issue in the family courts of concern is the weaponization of the child by the allied parent. So fundamentally, the pathology in the family courts is the spousal emotional and psychological abuse of the ex-spouse, the targeted parent, by a narcissistic, borderline, dark personality parent using the child's induced pathology and the legal system as the weapons of spousal abuse, and which is a DSM-5 diagnosis, V995.82, spouse or partner abuse psychological. Okay, so I'm giving you the diagnostic code numbers. Okay, you need to start assessing this and protecting people when they need protection, children, parents, spouses. Okay, that's our obligation as doctors. The child psychological abuse emerges from the spousal abuse, in that by weaponizing the child as an instrument of spousal abuse, the allied parent creates such significant pathology in the child that it rises to the level of child psychological abuse as well. That's creating a shared persecutory delusion of factitious attachment pathology in the child is psychological child abuse. But fundamentally, the child abuse emerges from the spousal abuse motivation. Okay. So the secondary gain, that's why it's important to understand for treatment-related purposes what the secondary gain is to the allied parent from producing pathology in the child. Because we're going to have to remove those rewards, one of which is spousal abuse. So we have manipulating the court to is one motivation, one secondary gain. The motivation to produce pathology in the child is to manipulate the court's decisions regarding child custody. Second is they produce the pathology in the child to psychologically abuse the targeted parent, using the child and the child's symptoms as the weapon. And the third secondary gain or reward is using the child as a regulatory object to meet the parent's own emotional and psychological needs. So in order for us to treat the motivation of the parent to produce pathology, we're going to have to identify what's motivating them so we can turn it off. We can stop it. We can interfere and intervene and disrupt the rewards they are getting for producing pathology in the child. So the solution is a clinical diagnostic assessment. We need to get an accurate diagnosis so we know what to do. Treatment for cancer is different than the treatment for diabetes. So in all cases of severe attachment pathology surrounding court-involved custody conflict, a child rejecting a parent, a proper risk assessment for child abuse needs to be conducted to the appropriate differential diagnosis for each parent, all of them, routinely. And we should get a second opinion on that, because the appellate system in healthcare for a disputed diagnosis is second opinion. The legal system is an adversarial system. Any diagnosis we return into the legal system will become a disputed diagnosis by one party or the other. So let's obtain a second opinion and even third opinion through telehealth at the initial diagnostic assessment. Okay. That's why telehealth exists, for professional to professional consultation. Psychologists can be anywhere in the computer. We can travel to different locations through telehealth through the computer. There will need to be an on-site psychologist who's conducting the clinical diagnostic assessment. However, we can also, or in addition, we can also get diagnostic second opinions on the assessment. And we should do that because we need an accurate diagnosis and we need to stop the fighting around these children. So we need to get it all together, get all the doctors together, let the doctors do what the doctors do, return an accurate diagnosis that the court can then rely on for its decision making as well. And we can develop an effective treatment plan to fix things with an outcome measure that shows we fixed it. So here's what the National Academy of Sciences, Engineering, and Medicine say in their paper, Improving Diagnosis in Healthcare. Clinicians may refer to or consult with other clinicians, formally or informally, to seek additional expertise about a patient's health problem. The consult may help to confirm or reject the working diagnosis or may provide information on potential treatment options. Clinicians can also recommend that the patient seek a second opinion from another clinician to verify their impressions of an uncertain diagnosis, or if they believe this would be helpful to the patient. So second opinion is what we do in healthcare. We do it all the time. And the reason we do it is because it improves the quality of healthcare services. It improves our diagnosis over here. It improves our diagnosis when we have second opinion consultation. So this is child abuse. We need an accurate diagnosis. Let's do that. So here's my recommendation. And this recommendation to everybody out there, I'm recommending this to parents, get court orders, do this, is you have two litigants in the legal system. Each litigant is alleging child abuse by the other. So litigant one, the allied parent, is saying, oh, it's the child is being malevolently treated some way. There's child abuse by the targeted parent. That's why the child doesn't want to be with them. That's allegation one. The targeted parent, litigant two, says, no, I'm not abusing the child. This is child psychological abuse by the targeted parent who's creating a delusional thought disorder and false factitious attachment pathology for their own stuff. And so we have two litigants, each making counterclaims of child abuse by the other. So we're going to need a proper clinical diagnostic assessment to find out which parent is abusing the child. It's going to be a disputed diagnosis one way or the other. So let's allow each litigant to appoint a second opinion doctor to participate in telehealth in that clinical diagnostic assessment. We'll get a 3-doctor opinion, majority opinion or the primary opinion from the assessing professional, and then 2 second opinion consultations. So let's do that. And then the court can rely on that for its decision-making. It can look at the 3 reports, just use all the evidence before it, make its decisions, and we can move into a treatment plan based on the diagnosis that is returned on that situation. And so I recommend this be sort of the standard approach for getting a clinical diagnostic assessment, is you get somebody to do it, forensic evaluator, forensic people psychologists would be good for that role if you stop doing custody evaluations and get over and do clinical diagnostic assessments. And then you can be also second opinions to each other, applying the knowledge, applying diagnostic criteria and the knowledge about delusions and factitious disorder. And we all come together to get an accurate diagnosis for the court's decision making. And so let's do that. And let's provide the court and these children with the highest caliber of professional mental health services. And we do that by consulting, by providing second opinion to the diagnostic situation. Now, here's what that would look like longitudinally. So we have the court, we have the 2 litigants, and we get the second opinion on the diagnostic assessment there in the center. That diagnostic assessment, that diagnosis, goes back to the court for the court's decision making, and it goes forward into the treatment as the foundation for the treatment. Diagnosis guides treatment. So when you have two consultants on the diet, you also have those same two consultants as it moves into the treatment, as it continues on. So that supports the treatment then going forward, response to intervention, or if there's issues that ever arise again. So this is right there is the model for how to get high quality mental health services in the family courts. And let me say something. Look at me. I'm an old guy here. Okay. You look at my Vita. I've done a lot of stuff. This is where I'm winding up my career. Okay. That the solution for the family courts has to be beyond experts and fighting and it has to be systemic. It has to be the healthcare system responding to a specific type of pathology in a specific type of context. And so this is a specialty domain over in the family courts. We got family court involvement that you don't have that with ADHD, autism, anybody else. So, but we've had 40 years of experience with forensic custody evaluation. It didn't work. So let's use the knowledge, though, to revisit the issue of how is the mental health system responding to the narcissistic, borderline, dark, delusional thought disorder, factitious pathology, child abuse pathology, one way or the other, pathology in the family courts. And let's bring a reasoned professional approach that's based or that is informed with our prior failure, our prior misjudgments. So let's get back into clinical psychology and get the courts and get these children the highest caliber of professional services, which they deserve for their decision making. One of the prominent implications of accurate diagnosis is the continued visitation schedule. I just presented this to the APA. It's available on Amazon. It's out there. It's a treatment approach for the pathology in the family courts. But it's a treatment approach for FDIA, for a factitious attachment pathology imposed on a child. It's not a treatment for authentic child abuse. So that's for the continued visitation schedule, adjusting the schedule based on the child's symptoms. That is the treatment for a factitious disorder imposed on another. Now, you'll also have the delusion there and the child abuse, but that we're with the continued visitation schedule, we are intervening on the allied parents' motivations for creating the pathology. We're taking away those secondary gain motivations so that they will no longer be motivated to produce the pathology in the child. The moment they're no longer motivated to produce pathology in the child's free, and hey, everybody's free, and we can go on with the situation and life and school and everything because we've solved it. So we're for FDIA, factitious disorder imposed on another, for secondary gain, the treatment is to intervene on the secondary gain, the rewards. Behavioral psychology is being rewarded. And so as long as it's being rewarded, we're going to see a high frequency of the behavior. We need to take away the reward for the behavior. It's behavioral psychology. It's So that's a continued visitation schedule, is for the treatment of a factitious disorder imposed on another. It is not the treatment for authentic child abuse. In fact, it's exactly the wrong thing to do for authentic child abuse, because in the continued visitation schedule for the factitious disorder, we are going to be essentially discounting the child's complaints about the targeted parent. The child's going to say, I'm being maltreated by the targeted parent. We're going to say, no, you're not, because not only did we assess it, we've got a family systems therapist talking to you and the ratings every week. No, you're not being abused. That's not abuse. Okay, so we're going to be discounting the child's allegations based on our diagnosis and, get second opinion, because we got to get an accurate diagnosis. Because if the child is actually being abused by the targeted parent and we discount their allegations, we say, no, you're not being abused. Go back and be with that parent. No. That's not what we do for authentic child abuse. So we need to know, okay, is it a factitious disorder or is it authentic child abuse? Because a continued visitation, we can treat that if it's factitious, but it's not the treatment for authentic. So what's your diagnosis? Now, here's the diagnostic criteria for a factitious disorder imposed on another from the ICD-11. So it's 6D51 FTIA. It's 300.19 in the DSM-5. So a factitious disorder imposed on another is characterized by feigning, falsifying, or inducing medical, psychological, or behavioral signs and symptoms or injury in another person, most commonly a child dependent, associated with identified deception. So let's apply those diagnostic criteria. The allied parent is inducing psychological symptoms, and behavioral signs and symptoms in the child dependent in order to deceive the court and mental health professionals about the parenting of the targeted parent, making allegations are abusive when they're not, based on these false induced child symptoms. Now, the second part of the ICD-11 criteria, the individual seeks treatment for the other person or otherwise presents him or her as ill, injured, or impaired based on the feigned, falsified, or induced signs, symptoms, or injuries. So let's apply those. So the allied parent seeks court interventions, seeks treatment from mental health people, individual therapists, and presents the child as being injured by the supposedly abusive parenting of the targeted parent and as impaired in their parent-child relationship with the targeted parent. So they're presenting the child as injured and impaired, seeking treatment or court orders to protect the child because of the induced signs and symptoms of the attachment pathology that's false. It's a factitious attachment pathology. So those diagnostic criteria are met. Okay, if there's no child abuse by the targeted parent, then it's a factitious attachment pathology. And so I've presented on the APA, on the continued visitation schedule, just in 2024, Division 41, Psychology and the Law Society. I went over, it was in Seattle. I took a little ferry over and went and presented to the APA on how to conduct or manage and run a continued visitation schedule in the family courts. And then I went onto YouTube and used my same slides and presented that same exact APA presentation up on YouTube. So it's up on YouTube as well if you want to go look at that, about the continued visitation schedule. So in summary, in my recommendations of how to protect children in the family courts from child abuse and parents from spousal abuse, and how to get courts accurate information about abuse issues with the family that the court can rely on confidently for its decision making surrounding the child. Here are my recommendations. So basically, stop using euphemisms, comply with ethical standards, proper risk assessment for child abuse, and then get a second opinion on the diagnosis. So number one, stop using euphemisms. For child abuse of made-up pathology labels that hide the child abuse from the court's understanding and that prevent effective treatment for the child abuse. As a psychologist, it is incumbent upon you to know the pathology you're working with. In the family courts, we are working with child abuse pathology. Do not cover it up using euphemisms. Use the word child abuse and use the DSM-5 for your diagnoses. Do not rely on made-up pathology labels. Stop it. That's just masks your ignorance. It's compensating for your ignorance when you have to rely on made-up pathology. So it's not parental alienation. It is psychological child abuse. It is not resist-refuse dynamic. It is psychological child abuse. It is not parent-child contact problems. It is psychological child abuse. Okay. So now, the APA Ethics Code, Standard 2.04, 2.01, 2.04, requires you apply the established scientific knowledge of the discipline first as the basis of your opinion. So first, before you offer up any of your made up pathologies of parental alienation, resist, refuse, parent-child conflict. Before you start offering those as things, as diagnoses or as pathology, you are required to first apply attachment, family systems, personality disorders, complex trauma, delusional thought disorders, the DSM-5. Apply all of that established knowledge first. And then if you need your parental alienation or something because it doesn't explain it, the DSM-5 and all the established knowledge about attachment, personality disorders, and complex trauma doesn't explain the pathology in the family course, and you need some sort of new form of pathology, then you can make your new form of pathology proposals after you apply knowledge, after you fulfill your ethical obligations under Standard 2.04. Okay, so not before. So stop using euphemisms. They hide the child abuse and they prevent our ability to intervene on the child abuse. Number 2, all psychologists should comply with all ethical standards, including Standard 2.01 and 2.04. The established scientific and professional knowledge of the discipline required for competence and required for application is attachment system and attachment pathology, delusional disorders, child abuse and complex trauma, personality disorder pathology, family systems, constructs, and principles. Okay, so all return to ethical standards of practice that are required, mandatory, and that are being violated currently. And so I have Standard 1.04, 1.05, 1.04 I'm doing now. You're violating ethical standards of practice if you are not competent in the necessary domains of knowledge. It's not my obligation to educate you. It's your job to already know. And the patient should never have to explain the pathology to the doctor. If you have your patients explaining the pathology to the doctor, you're not competent with the pathology. Okay. If Dr. Childress is explaining the pathology to you, you're not competent by demonstrated need to be educated about what the pathology is. So you have obligations under 2.03, maintaining competence, if you haven't, to initiate your own self-education under Standard 2.01, C and D. And that's not happening in the family courts. And as a result, the family courts and the children are receiving a horrifically poor level of professional services. And I cite to the New York Blue Ribbon Commission on Forensic Custody Evaluations, dangerous, harmful to children, lack scientific and legal value. Recommendation 3, risk assessment. In all cases of court-involved custody conflicts surrounding severe attachment pathology displayed by the child, a child rejecting a parent, directional change in the primary motivational system, a proper risk assessment for child abuse should be conducted to the appropriate differential diagnoses for each parent. All cases, routinely. Recommendation 4, consultation. A diagnosis returned to the legal system will be a disputed diagnosis by one party or the other. The appellate system in healthcare for a disputed diagnosis is second opinion. Therefore, all diagnoses returned to the legal system should be accompanied by a second or even third opinion consultation through telehealth. So that is my seminar or my offering to the AFCC Symposium Theme from 2024 about protecting the well-being of children, which is essentially assessing, diagnosing, and treating child abuse issues in the family courts. All mental health professionals have duty to protect obligations. The only cause of severe attachment pathology is child abuse, range parenting, So in all cases of severe attachment pathology in a custody conflict, a diagnosis of child abuse should be returned. Okay, so we should be getting diagnoses of child abuse one way or the other from you forensic psychologists, and we're not. We're not getting a diagnosis either way, which means you're misdiagnosing the pathology one way or the other. Because we should be getting a diagnosis of child abuse because that's the only thing that produces that symptom. But we're not getting a diagnosis of child abuse. So the first thing we need to do is evaluate whether there's been a misdiagnosis in the matter. That's going to require you to diagnose the pathology and support your diagnosis so we can tell if you've misdiagnosed it. And let's not misdiagnose it. Let's get an accurate diagnosis so that we can properly protect the child and protect the spouse, the ex-spouse, and get effective treatment for the child abuse in the family courts. So with that, I'll wrap up my seminar here today and talk about other aspects of the court-involved pathology